participants, and and vice versa. So
Mantap.
yeah, and there will be also Indonesian Sign Language interpreter, and also with closed captioning as well.
Good.
Great. Yeah. All right. I'll see you in about 12 minutes. Yeah. Pak Basit mau coba?
Oh, another question. Dina, you are still there?
I'm here.
Who is up first?
Sorry?
Who is up first?
Oh, Pak Andrew. Andrew,
Okay.
and then Joe, and then yourself.
Okay.
So
Okay,
both Andrew and Joe will talk about Australian context, and then you can start with your work around the topic in Indonesia.
Yeah.
Like
Provide
that,
a historical overview.
Yeah, okay. And then Ibu Yeni, and then Ibu Mamnuah.
Ibu Yani di sana?
Yeah.
Di mana?
Oh, belum hadir kayaknya, belum masuk.
Belum hadir. Okay.
Belum masuk ya. Good, Pak Basit. Oke.
Bentar, baru loading Bu, sebentar Bu. Baru slideshow-nya masih loading sebentar.
Oh, oke ya.
Di halaman berapa Bu videonya?
Halaman 5.
5 sama?
Sama, sebentar ya. Lupa.
14 ya?
Iya, kayaknya. Ya. Tinggal diklik, kan ada tanda kliknya ya. Yeah, good. Okay. Sip. Bagus, Pak Basit. Great.
The Every Nurse's Business continuing
Yeah. Thank you, Pak Basit.
development program aims to build.
Yo, sama-sama. Untuk live transcription-nya gimana, Bu?
Sorry apa? Gimana Pak Basit?
Live transcription-nya, sisinya.
Oh iya, ini saya lagi Mahali sebentar akan ini menyampaikan siapa namanya.
Ya. Saya tunggu ya, Bu ya. Oke.
Iya. Ibu Mamnuah sudah di sini belum Bu Cesa?
Belum ada.
Oke.
Selamat pagi kawan-kawan semua. Selamat pagi Bapak Ibu sekalian. 5 menit lagi kita akan mulai webinarnya. Sambil menunggu para peserta mulai berdatangan, saya Rifal Ahmad. Saya transisi proses ke Mbak Dina buat pagi ini sambil mengumumkan beberapa hal untuk para peserta ya. Untuk sesi kali ini kita akan ada 5 narasumber. Kita akan membahas tentang disabilitas mental dan intelektual dan hak atas kesehatan. Buat kawan-kawan yang sudah hadir, sesi kali ini kita akan ada 3 pembicara dalam bahasa Inggris, 3 atau 2, tergantung Pak Hans akan bicara dalam bahasa Indonesia atau bahasa Inggris. Dan mohon buat kawan-kawan untuk menggunakan fitur interpretasi yang ada di bawah layar. Bagian bawah ada lambang bola dunia dan di situ ada tulisan interpretation. Tolong diklik nanti ketika ada pembicara dalam bahasa Inggris. Nanti akan diinterpretasi oleh Mas Hikmat. Jadi teman-teman bisa menikmati paparan dalam bahasa Indonesia. Bagaimana seperti yang beberapa sesi-sesi sebelumnya, kita akan dimulai dengan webinar ini dan kemudian sampai jam 10.15 kita akan break 15 menit dan kemudian teman-teman akan masuk lagi ke ruang yang baru, ruang aktivitas kelompok. Di situ kita akan berdiskusi bersama-sama. Chair kali ini Ibu Dina udah siap, udah pakai selimut. Udah pakai apa itu? Shawl, karena dingin ya. Melbourne dingin pagi ini. Jadi buat kawan-kawan yang sudah hadir, bisa bersiap-siap untuk menikmati sesi webinar kali ini. Saya serahkan ke Mbak Dina. Masih ada 2 menit sebetulnya. Sambil menunggu yang lain, mungkin bisa mulai memastikan apakah para narasumbernya juga sudah hadir untuk sesi kali ini. Silakan Mbak Dina.
Baik, terima kasih Pak Rifal. Terima kasih untuk sudah membuka ya pagi ini. So I would like also to greet all the speakers from Australia, from Melbourne, and also from New South Wales, Southern Cross, Professor Andrew Cassin, and then Dr. Joe Spong, Professor Hans Paul, and already here also Ibu Mamnuah, Dr. Mamnuah from Aisyiyah University, and also Ibu Yeni Rosa Damayanti, one of the Indonesia leading disability advocates. I'm sorry that I am probably going to mix Indonesian and English, if you don't mind, Pak Hikmat. So we are very lucky to have all the necessary accommodations that might be needed by everyone who is participating and also joining this webinar. So there are English translation, there are sign language interpreter or JBI, Bisindo, and also the closed captioning or Tak Karir. Okay, without further ado, I would like, now 11 o'clock. So I would like to welcome Professor Andrew Cassin from Southern Cross University, who is Professor of Autism and Intellectual Disability. Professor Andrew Cassin is also currently a leading scholars in the discipline of mental health and intellectual disabilities, and also He runs a nurse practitioner clinic for people with autism, their families, and those that work with people with autism at the Southern Cross University Health Center. So Pak Hendru ternyata juga sudah mempunyai kolaborasi dengan dosen dan peneliti di Medan ya. Jadi kita senang sekali, saya juga baru mengetahui hal tersebut. Oke, Pak Andrew, you have about 15 to 20 minutes for your presentation this morning. Time is yours, Pak Andrew.
Thank you. Thank you for having me, and thank you for the welcome. I'm not actually seeing my slides pop up. So up there. Yeah. I'm presenting from the north coast of New South Wales, which is just below the Queensland border. Unlike Melbourne, it's a lovely day here. You can see out my window. We're in a subtropical area. I'm going to just really, in a very short time this morning, present some ideas that hopefully can build curiosity and start a discussion. We've got quite a lot of terrain to cover to even talk about what autism and intellectual disability are, and then to think about how to promote inclusion to hopefully reach a situation of equity in terms of health outcomes and experiences with the health system. So I'm going to start off just talking a little bit so we're all sort of understanding what I'm talking about autism and intellectual disability. Can we go to the next slide, please? So autism and intellectual disability are both developmental disorders. And whilst they begin in the early developmental period and are often recognized in children, they continue across the lifespan. And so that means that we need to focus on not only care of children with intellectual disability and autism, but right up to our elderly citizens and people who are requiring aged care. They impair aspects of cognitive, physical, language, and behavioural functioning. And we're not talking about a small group, we're talking about very roughly 5% of the population. So we're talking about a large group of people. Sometimes it's difficult to talk about two very separate sort of things, autism and intellectual disability, and make sense of it. But this is a bit of a different case in that about 27% of people that have autism also have intellectual disability. We call it comorbid. They're not part of the same thing, but they occur together. And in fact, intellectual disability occurs far more frequently in people with autism than people who don't have autism. Can we go to the next slide, please?
Slide berikutnya, Pak.
This slide's important because when we focus on autism and intellectual disability, often we have a behavioural focus. We think about how do people with these things behave differently? But the real key to understanding both autism and intellectual disability, and then how to make adjustments to practice to promote inclusion, comes from understanding neurodiversity. And neurodiversity is just thinking differently, in that in our population, we don't all think the same. We came to understand the concept of neurodiversity largely through looking at autism, because autism is a very different thinking and information processing style. I can't really do justice to talking about this in such a short time other than to build curiosity and encourage you to explore this further. Today, what I'm going to talk about is autism and intellectual disability, but largely what we've found in Australia in terms of health outcomes and the barriers to inclusion, and actually some of the challenges we're facing, and that's kind of important. So if we think about autism and we think about a difference in thinking, and again, we don't have time to unpack it, people with autism are primarily visual processes of information as opposed to thinking in words or linguistic processes. They have a lack of abstraction ability and a theory of mind deficit. So there's actually a fundamental difference in thinking. People with intellectual disability don't have a fundamental difference in information processing style and thinking style, but the speed they can process information and the volume of information that can be processed at any time are different than those who are typical thinkers or those who don't have intellectual disability. Next slide, please. There's a clear link between thinking and behaviour. And in the slide that follows this one, I'm going to show you a short video of this man here, Harrison. Harrison's actually an actor that we employed on a project we've got at the moment, and Harrison has autism. Harrison at the start alludes to difficulty knowing when to press a buzzer, something very simple in hospital. But if we think back to a lack of abstraction ability, actually knowing when to press a buzzer is quite complex. If someone in a hospital, a doctor or a nurse or another professional says, press the buzzer when you need to, actually it took Harrison several weeks to work that out and decode it, because when do you need to press a buzzer? It wasn't a concrete instruction at all. Let's just have a few minutes and listen to what Harrison has to say on the next slide.
It took me a while. I was in hospital for a month, but it took me a while to kind of get to that point of being comfortable to press the button, to ask for help when I needed it. And yeah, when things are busy or when like the nurses are kind of rushed and stuff, and I mean, I guess like talking about me, like that's kind of, if the nurses are talking about me, or kind of like you'd prefer them to talk to you, not about you, if you're right there.
That was a very simple grab off a video, but in it, there's actually a lot to decode. The reason Harrison didn't know when to press the button was lack of abstraction, but with a lack of theory of mind, the ability to put yourself in someone else's position and guess what they're thinking, it's even very hard to know whether people are addressing you, who they're talking to. And so there's a real mismatch between the way people with autism think and typical thinkers think. And there's a mismatch of behaviours, and often that's misunderstood, and that causes lots of problems with inclusion. Again, today's just to build curiosity, but also to give a lot of hope, in that if you can make sense of those thinking differences, the adjustments that can make a huge difference are very small and very easy. And it really gets down to things like concrete instructions. Without making those adjustments, internationally and in Australia in particular, we've identified that health outcomes are terrible for people with autism and intellectual disability. In fact, a case can be made that of any group in Australia, those with autism probably have the worst health outcomes. They're dying disproportionately early of things that are preventable and having a far greater burden of chronic illness. And so we've got a lot of work to do here to promote equity and inclusion. And when you think about it, it's kind of simple to do. What we do know is that people with autism and intellectual disability present to the emergency department more often, have more chronic illness, and when they do get admitted to hospital, tend to have longer stays. And so there's actually a driver for promoting inclusion and building equity, not only from the experience and outcomes for the people with autism and intellectual disability, but for the fiscal or financial outcomes of the hospital system. Because if we get this right, then care for these people will be less expensive, as well as making a huge difference to the quality of life. Next slide, please. Some of the barriers to healthcare from health professionals that we've, the perspective of health professionals, is knowing how to communicate, the confidence to make adjustments to practice, feeling comfortable with working with people that behave in a way that's sometimes hard to understand and difficult, and don't respond to the ways that typically work in terms of helping people settle and comply and adhere to hospital or treatment regimes. And we found here in Australia huge curriculum gaps Now, I'm going to talk a little bit about nursing because that's where I'm working at the moment. We have a large funded project to build capacity of nurses in mainstream healthcare settings to care for people with autism and intellectual disability. But just to generalise, we, a couple of years ago, led by Professor Julian Troller at the University of New South Wales, did some curriculum audits of both nursing and medicine and found that in Australia, there's a very small amount of curricular content related to autism and intellectual disability across both disciplines. And there's very few clinical experiences for students working with people with autism and intellectual disability. And that gave us some clues to actually where some of these gaps are coming from and how to build capacity. Next slide, please. At the beginning of a project I've got now, which is funded by the National Disability Insurance Scheme, we did the first large-scale national survey of registered nurses. And this is the first we identified internationally written in the English literature to look at nurses' experiences of education across their undergraduate, postgraduate, and continuing professional development. We also looked at nurses' self-perceived confidence and comfort in caring for people with intellectual disability. And we were able to make some fairly good links between those things. I'll just give you a quick profile because we don't have a lot of time and I've got a lot of slides. And if we just jump through to the next slide. Next slide, please. We found that those who had had a clinical placement that had a specific focus on autism and intellectual disability were more likely to feel prepared. But both groups, those who from their undergraduate education and their clinical placement were really pretty likely to feel not prepared at all or just moderately prepared. Next slide, please. We found that there was a direct link between their undergraduate exposure and their postgraduate exposure, so their education or their continuing professional development, and their confidence to care for people with intellectual disability and autism, and to address healthcare needs. And so again, the solution to building equity really does seem to be grounded in education and clinical experience that's mentored. Next slide, please. We found that the knowledge and how knowledgeable nurses felt across contexts varied. So we're looking at nurses who are working in mainstream healthcare. We found that those in a specialist context had disproportionately more confidence and felt knowledgeable, as you'd expect. But surprisingly, there was still a fairly large group that didn't feel super confident, very confident. That was in pediatrics, again, stronger. There was a bit of a focus. But as we get to the general hospital, you can see that the self-perception of being knowledgeable and prepared drops off dramatically. And what I was saying earlier is that when people with autism and intellectual disability get admitted to hospital, often their stays are more complex and long. And so you think there has to be a link between education, confidence, and preparedness to care for these people and the health outcomes. Next slide, please. You can just see from these bar graphs and in the references, there's actually some papers that are easy to access, which go through this in more depth. But we found clear links between self-perceived knowledge, of course, and confidence. If you're not confident and someone's behaving in a way that you don't understand, it's very easy to avoid them. And in fact, at a time where they need more care and slightly different care, often people with autism and intellectual disability aren't getting it, and that links to the outcomes. Next slide, please. So I keep talking about reasonable adjustments. Well, under the national conventions, and it flows down in Australia, of course, international conventions and that talk about rights to equitable care, and it flows down into our national commitments and then our state laws. We talk about reasonable adjustments. And of course, that's just adjusting your practice based on the understanding that people think differently. And there's a clear link between their thinking and their behavior. And so if you can support understanding and support people, then you can allow access. We found that knowledge of reasonable adjustments was quite small, even though people thought they were doing it about half the time. The word reasonable is really easy to decode. It just means that if it's not excessively difficult or expensive, then it's expected that we can do these things under the international conventions. And so they are quite easy to make. It just means we need a little bit of education and we can make a huge difference. Next slide, please. So we've got a project, and before we click on it, I'll tell you a little about it. We've created a free continuing professional development site, and this is live at the moment for Australian registered nurses. And we're hoping that providing accessible education, we can make a big difference. But of course, this is a very small first step, but really achievable. And so I'll show you a little bit about what we're doing on this promotional slide. Yes, please play.
The Every Nurse's Business Continuing Professional Development Program aims to build the capacity of registered nurses when addressing the healthcare needs of people with intellectual disability and/or autism. The site offers foundational, intermediate, advanced learning levels and opportunities to learn interactively with your peers, people with lived experience, and experts in the field. Let's talk together, work together, and make things better for people with intellectual disability and/or autism in mainstream health settings. Start your learning journey today.
So across our learning site, we go from very foundational right up to having synchronous learning sort of processing groups where nurses can come along and chat with experts. But we introduce very basic ideas like positive behaviour support, which is that all behaviour has a function, which means that people do stuff for a reason. And that actually gives us a clue to start thinking about, well, what are they trying to achieve, or what is the behaviour trying to achieve, and how can we actually work with them to develop behaviours that allow them to participate in healthcare and hopefully get better outcomes. We talk about social stories, which is ways to give chunks of social information, which helps sort of balance that theory of mind deficit. So really basic concepts which can make a huge difference to practice and promote inclusion. Here's some references. They're not all full text, but two of them are actually open access. The other thing is I've written a book and a shameless self-promotion, but it's called Young People, Adults and Autism Spectrum Disorder, published by Nova. And that's a fairly simple book, which actually gives an introduction to a lot of these ideas, but also looks across the age span about how some of the implications are from neurodiversity and some of the things that can be done to promote inclusion right up to aged care. I've got a habit of talking way too much. And so I think given we're nearly right on 20 minutes, I should pause and give an opportunity for questions.
Okay, thank you so much, Andrew. That was really insightful. And I think for myself, this is all new for me. And I'm sure there are also a lot of people like myself here in the participants in the audience group who learn so much and learn a lot of new things. So I've asked I asked our participants to pop in their question in the chat box, and so far we've got 3. Let's see if we can answer all of them. But the first one I would like you to be able to ask is a question that comes from Pak Romi. So he's a very important person in Nusa Tenggara Barat, in Lombok or Mataram, yeah, in Lombok, NTB. So he works for the local health offices, part of the government office. So the question from Pak Romi is, apakah untuk memberikan layanan kesehatan for people with autism or intellectual disability, the nurse needs to have a license? And if there is any particular certifications that the nurse must have in order to provide that services. And also, he would like to ask if it's possible for you to share the professional guidance that you mentioned in your slides. That was the first question for you, Andrew. You can answer.
Just so I understand, I think the question was, is there a particular certification to work with people with autism?
Yeah.
And in Australia, there used to be, it was a specialty with a certification, but we moved to a comprehensive nursing register. So all registered nurses now are expected to have the capability to work with people with intellectual disability and autism. But as our research has shown, the case is that there hasn't been the curricular content that's actually enabled nurses to do that well. So we've got a long way to go to promote inclusion and to get equitable health outcomes in Australia. And that's our work that we're embarking on. In terms of developing resources, that's the project we're proposing at USU at the moment, is to actually repeat a survey similar to the one we've done in Australia, just to see where the needs are, and then to be able to develop these programs. And I think sharing is going to be really useful, and we're very open to doing that in a way that's meaningful. And I guess the news I bring is that we're all at a beginning point of understanding how to promote better health outcomes. And so I'm sure together we'll all find solutions that may not only be locally applicable, but we can also then bring back and share internationally.
Okay. Thank you so much, Andrew. I have 3 other questions, but I can see all of them are quite related. And so I think I try to squeeze in the questions. The main questions will be, what is your advice or what is your insights on how society and also healthcare institutions support children with autism? And especially because in the context of Indonesia, one of the questions says that many of the children with autism, they are not out in public because their family, they have a very limited interaction with the social environment. And so therefore that creates an issue, right? So what is how society can support that? And also for the caregivers as well, to support children with intellectual disability, and probably you can share some experience or insights from Australia. Yeah, that's the second question.
Yeah, no, terima kasih. That's a big question, and but really, if we broke it down into the most achievable chunks, probably the first main or important point is getting good recognition, so diagnostic services, so that we can actually put a name to what's happening. The next step is education and families as well about what this is, because often there's a lot of misunderstanding about the causes or why this is happening. And that makes sense, because when something happens, we always ask that question, why? We ask, what is it first? And then we ask, how much is it? Is this mild, moderate, severe? As we try to think, well, what are the implications of this across someone's life? But then we start to ask, why is this happening to me as a parent and to my child? And so it makes sense we try and find reasons. So once we recognize what it is, then jumping to that next point of actually, to the best of our knowledge, why this is happening is really important, because it's not about some sort of, spiritual, religious, karmic thing that's happening. It's not about bad parenting. It's actually a biological thing that's happening. That mild, moderate, severe thing is really important too, because once someone has a child with autism and also intellectual disability, working out how that works, because with intellectual disability, you do have mild, moderate, severe, or profound, but with autism, you just have it, because the severity will change based on the person's context or what's happening around them. In a novel context, someone with autism will look far more impaired than when things are going in a routine, predictable, and comfortable way. So wrestling with these things, which are really quite easy to convey concepts, can make a huge difference. It can also then get us to that next step of, well, what is it in terms of neurodiversity or the thinking and information style? And it gets us to enabling parents to develop strategies, as well as school teachers and those that work with the people, to allow someone to get out in public so that they can learn the routines and behaviours which allow them to participate, so we can make a big difference. One really important point, though, is this not just happening in children, and there's going to be a lot of young people, adults, and even old adults where it needs to be recognised and diagnosed as well. So we need to have accessible clinics right across the age span where people can come and we can determine what's happening and then form a plan.
Yeah.
It also fills in, and I'm aware that there's going to be much more and good talk on mental health, but it starts to allow us to think about, some of those lines, because there's also very fuzzy lines between these things or constructs, these ideas of what we're calling things. So if someone comes to a clinic and it's not autism, then there needs to be somewhere to go and ask that question, well, what is it and how do we support it? Because something has brought them to the clinic.
Yeah. Okay, one last question, Pa Andrew. Maybe you can answer it very succinctly. We have a question from our participant who is diagnosed with Asperger's syndrome. So, what's your advice to raise? You mentioned in your presentation about working together between the healthcare and also providers and also the community. So, what is your advice for all the people who are here? How we should raise awareness around intellectual disability, Asperger's syndrome, and also other mental health issues in Indonesia and in the community as well. Thank you, Andrew.
And I think working together and exploring different possibilities is the way of how to do that. I mean, it's definitely about information, understanding, and discussions involving people who do have autism and intellectual disability in those conversations is really important, so that in an inclusive way we find those strategies. Education in terms of a health professional point of view is essential, and so that the right messages can get out there. How we can move beyond that, it's going to vary depending on the local context.
Thank you so much, Andrew. I know you need to go to attend your clinic. So on behalf of the organizer, I would like to express our gratitude and also thank you so much for being with us this morning. And I'm sure that a lot of us learned so much from your presentations and also from the way you answered some of the most important questions we got from our participants. So I would like to again extend our thanks, gratitude for you. Thank you so much, Pa Andrew. And hopefully, like I said, we will be able to see you in person one day in Jogja or in Medan or somewhere else, or in in NTB with Pa Romi. Thank you, Pa Andrew.
And thank you for having me. And I'm very happy to talk on the email if anyone wants to.
Ya, baik. Terima kasih. Teman-teman bisa mengontak Pak Andrew langsung juga kalau masih ada pertanyaan. Pak Andrew akan dengan senang hati menjawab. Oke. Okay.
Thank you.
Thank you so much. Okay, now we have our next speaker, my colleague from La Trobe University, Dr. Joe Spong. Dr. Joe is a lecturer in the Rural Department of Community Health Science at the La Trobe University here in Melbourne, but no, in Bendigo, about 1.5 hours from Melbourne. So Dr. Joe ini punya penelitian yang sangat banyak dalam hal tentang pengalaman klinikal dan juga non-klinikal di bidang neuropsychology, psychosociology, mental health, and also sleep research. So Dr. Joe will be talking about her recent research on issues around healthcare and also intellectual disability in Australia. Okay, 20 minutes for you, Joe.
Okay, I'm going to share this, but if you could let me know, Dina.
Yeah, you can share it now.
Okay. Sorry. I'm afraid I don't see the share function, Dina. So here we go. Okay. So is that showing now, Dina?
Perfect.
Okay, I'll just make it.
Oh, yep, great.
Okay. Well, firstly, thank you very much, Dina, for the invitation to talk at today's session. I would like to take the opportunity today to talk about a project that we actually conducted in 2019, just prior to the COVID pandemic. The aim of our project was to explore preparedness and training needs for a rural regional public mental health workforce in providing care to people with intellectual disability and mental illness. And this was a project that was funded by La Trobe University Grant Ready Scheme. And it's actually got a lot of similarities to the previous presentation. So we'll just start with some background. People with an intellectual disability are 2 to 3 times more vulnerable to the development of a mental ill health condition and compared to the general population. Yet rates for accessing mental health care are lower compared to the general population. And what's likely contributing to these lower rates are the many barriers that people with intellectual disability face when trying to access and receive mental health care. People with intellectual disability have a heightened risk of what's called diagnostic overshadowing. And this is where mental health presentations or symptoms are attributed to the intellectual disability only. Cognitive and communication deficits that are associated with an intellectual disability can mean that care is complex. People with intellectual disability or those people who are supporting them may have difficulty in understanding or communicating about the mental health changes that they're experiencing. And sometimes there's atypical presentations of a mental ill health condition, particularly for people who have a severe intellectual disability and communication difficulties. So, for example, there could be behavioural presentations of a mental ill health condition. So it's really important that mental health professionals don't focus solely on the presenting symptoms or mental health indicator, but actually investigate further for what's contributing to those symptoms. The relationship between biopsychosocial factors and mental ill health indicators also requires further investigation to ensure that treatment is appropriate. So, for example, maybe the presentation of a depressed mood and investigating whether or not there might be changes in the person's environment or their routines or the people who are supporting them. Or maybe there could be an underlying physical health condition or a genetic predisposition. So that's really, again, important to investigate further. So these are just some examples of where, for people with an intellectual disability, there could be no investigation or under investigation of a mental health condition, which unfortunately could result in a worsened condition, exacerbated behaviours, insufficient care, or poor or incorrect treatment being applied. For people who live in regional and rural areas, there's even further risk. And this is because there's limited health services compared to metropolitan areas. There's higher rates of intellectual disability, and there's a tendency to underuse public mental health services. So it's really essential that our mental health workforce are prepared and trained well so that they can apply their skills and provide the comprehensive and equitable mental health care that people with intellectual disability have a right to receive. And this might mean making some adjustments to standard models of care in mainstream mental health services. Now, the literature is showing us that mental health professionals are feeling inexperienced and underskilled and lacking in confidence in knowing how to provide the care that's required for people with intellectual disability and mental ill health. Now, in 2018, there was a national roundtable held in Australia where approximately 130 experts came together to reflect on and discuss the mental health needs of people with intellectual disability. And what resulted from that roundtable were a set of recommendations to these 8 elements, which together are believed to reflect an effective mental health service for people with intellectual disability. Now, within these elements is element 6, which is workforce development and support. And one of the recommendations for this element was or is to upskill the mental health workforce to a minimum standard. But to do that, we need to have some further understanding of what the training needs are of the workforce and their level of preparedness. So we wanted to take a similar approach to 2 of our co-investigators who a couple of years prior, through a survey study, explored the preparedness and training needs across the state of New South Wales in Australia of the public mental health workforce in terms of intellectual disability and mental ill health. But we wanted to do this for a regional rural public mental health workforce. And we wanted to go a bit further than survey data and also collect what's called qualitative data. So I'll explain that a little bit further in a moment. So we invited all staff who were employed by a regional rural mental health workforce or service to participate in any of a survey, an interview or a forum. And we used the survey to collect information on the staff demographics, on their attitudes and confidence in providing care to a person with intellectual disability and mental ill health. And we also asked about their education, professional development and experience in this area. And then we used the interviews to further explore key findings that were coming out of the New South Wales study, and that were coming out of our preliminary analyses from our survey. And we also used the interviews to talk about barriers and enablers and resources that are required and provided to care for people with intellectual disability and mental ill health, and their experience and education and professional development and their understanding of opportunities to engage in that. Then we took our preliminary findings from the survey and the interviews to a forum where we asked participants who were attending the forum just to reflect on the findings and to discuss them. And we also asked for their opinions about future education and training. So I'll just go over some results now. Our survey respondents were mostly female, above 25 years of age. They were mostly from a nursing discipline. Half were employed full-time. The majority were in a clinical role and working with adult clients. We had a nice balance of people working in the community and within the hospital settings. Almost half of our sample had greater than 10 years experience as a mental health professional. The majority of our sample had interacted with people with intellectual disability professionally, and a large portion also had interacted with people with intellectual disability outside of their professional role. And these trends in the demographics were similar to the previous New South Wales study. I'm just going to present some of our key findings today. In terms of the attitude survey, we asked participants to indicate their level of agreement to a set of statements using a 10-point scale, where 1 equals agree and 10 equals disagree. And what we observed, this is just an example, sorry, of one of the statements for you to see, and this is just our finding of the group responses. And what we observed was that there were consistent agreement by the group for statements that related to people with intellectual disability having the right to good mental health care and the right to the same access to services, to the recognition that their role includes caring for people with intellectual disability, and to good mental health care impacting on quality of life for people with intellectual disability. So these are really good attitudes coming through in the sample. The recognition that it is part of their role to care for people with intellectual disability, that people with intellectual disability have the right to mental health care and access to services, and that it will impact on their life. We also observed some group responses that fell in the middle of the scale. And what this means is that we saw some responses of agreement and some responses of disagreement. And these less consistent group agreement responses were for statements that related to resources and meeting the needs in mainstream mental health services, in terms of relating to communication regarding the staff member and patients understanding each other. And this third bullet point, which I think is also related to communication, particularly understanding whether the patient with intellectual disability may become more distressed and whether they would avoid or have difficulty with understanding procedures with people with an intellectual disability. So there seemed to be less certainty within the group around communication and if the resources were available to provide the care within mainstream services. In regards to staff confidence, we asked participants to indicate their level of confidence regarding providing care to a person with intellectual disability compared to a person without intellectual disability using a 7-point scale. And the 3 areas that showed the least confidence amongst the group were for recognising when a patient may have a mental disorder, understanding potential adverse effects of psychotropic medication, and also communicating effectively, understanding and being understood. So again, communication's coming through as an area of where confidence is of a concern. Despite the fact that the majority of our sample had received some level of education during undergraduate education or some level of training through professional development, only a small portion, 2 participants, felt that that was sufficient to meet their professional needs. Again, these are findings that were similar to what we observed in the New South Wales study. We wanted to explore these findings from the survey a little bit further through interviews. So we interviewed 7 participants working within the mental health service. They were mostly females, older than 25 years of age. The majority were working in the community, again, mostly from nursing, and just over half had greater than 10 years experience. And what we observed from the interviews were 3 key themes that were coming through. So I'll just discuss each now. The first one was vulnerability of the individual, and this was particularly in regard to difficulties associated with communication, specifically difficulties and impacts related to poor comprehension and an inability to express. So what we saw here was discussion around there being insufficient time to gather information for a really good quality assessment. And this had an impact on differential diagnosis. So for example, one of our participants said, with someone with an intellectual disability, I mean, an hour would, for a lot of people, would be enough for them to sit in a room and complete that assessment. But you need, I guess, more time and resources. With these poorer assessments, came poorer outcomes. And what that means was there was discussion around symptoms only being treated, this lack of exploration, investigation of what was contributing to those symptoms, or symptoms not being treated. And this was usually related to, again, difficulty with being able to communicate about those symptoms. And as a result, patients often becoming more unwell or inappropriate treatments being provided. So another participant said she couldn't express that or couldn't describe her symptoms very well. And unfortunately, she got sicker because of that. And so we needed to have more interactions with her. We also observed that when there were difficulties with communication, participants talked about a heavier reliance on carers to assist with information gathering and communication. But they also recognised that carers might also need a break, or there's maybe some carers that don't have the best interests at heart of the person with intellectual disability. The second theme was system and service constraints, and this is really where we saw discussion around inflexibility, institutional-like environments, and procedures and services that weren't being changed. And we also heard about a lack of collaboration between mental health services and disability services. So with this inflexibility, there was an impact on planning reasonable adjustments, which was previously discussed by Professor Cashin in terms of what reasonable adjustments are. In fact, when we had participants talking about adjustments, they described them in terms of being reactive rather than planned, and acknowledged that there is a need for them to be planned. And when there were planned reasonable adjustments tailored to an individual, there wasn't this recognition that the benefits of that might be seen for other patients, that maybe engaging in some adjustments for other patients would also be useful. The third theme was upskilling. There was a real acknowledgement by participants of the need to upskill and engage in more education and professional development, but they're faced with barriers of having a lack of time and opportunity to do so. So any resources really needed to be readily available. We're also talking about mental health service and mental health professionals who are working with people with a whole range of mental health conditions. So any opportunity that's provided to upskill in intellectual disability, it's competing against upskilling in other areas or other mental health topics. So we've got here participants who have said, we get 5 days a year of professional development training. And as I was mentioning before, there's a lot of competing demands when you work in a generic position. And another who said, we don't really get a lot of training around it because we don't see, there's not really a high proportion of people coming through with an intellectual disability. There was this real undertone of, yes, we know that it's part of our role to care for people with intellectual disability, but it's not really at the core of our work. Now, when staff are confronted with a lack of time and opportunity, there's a reliance on other team members who may have worked with people with intellectual disability and developed some specialised skills, or a desire to seek out advice from specialists, but those specialists are not always available or known to the staff. We took the preliminary findings from the survey and the interviews to a forum for further discussion. So our forum participants, again, they were all working within the mental health service. And there was real acknowledgement that there's a need for longitudinal assessment processes and other adjustments. So prolonged engagement with people with intellectual disability to get to know them better and to share information within the team so that the team can work together on patient-centred solutions. There was acknowledgement that there needs to be a focus on differential diagnosis of intellectual disability, mental illness and other components of dual diagnosis, the need for further education and professional development, but the acknowledgement that this is really difficult to achieve. And linked to this topic of further education, the need for collaborative problem solving and supports of patients with intellectual disability and mental ill health.
1 more minute, Jo, sorry.
Last slide now, Dina. So in thinking about future education and the findings from this study, perhaps we could consider moving away from traditional approaches where individuals try to specialise in a whole range of areas, but move more towards collaboration approaches. So maybe engaging in case-based learning approaches where we're sharing expertise, sharing problem identification and responsibility for implementing supports and treatments to address the patient's specific needs. And running 20 seconds over, Dina, but I'll finish here.
Thank you so much, Jo, for your elaborations on, I think it fits really well with what Professor Cassin mentioned earlier in his presentations, and I can see the link from both of your presentations. So I hope you don't mind to stay, and then we are going to move to our third speaker. So we've learned about Australia and what has been done, importantly about some of the research that have been done around how healthcare providers and also building the skills of healthcare workers in Australia in regards to mental health and intellectual disability. So now we move to Indonesia with Pak Hans Paul, Professor Hans Paul, who is based at the University of Sydney, but he is currently speaking from Melbourne. So Pak Hans, the same with Jo and Andrew, you have about 20 minutes. And if it's possible, can you use your, because you are in an open, so I'm not sure if the sounds will be great. But we can try, yeah. Thank you, Pak Hans. Pak Hans, you are still muted. Yeah. Now you need to unmute yourself, Pak Hans. Where's Pak Hans?
Di sini, I'm back.
Okay, all right. Okay, good.
Sorry, was masalah dengan email, dengan... Anyway, this paper is very different from what you heard before. And I will give a very scandalously brief history of psychiatry in the Dutch East Indies and Indonesia. I am officially a medical historian, although I've become much more interested in mental health care in Indonesia today and in the near future. Now, there is something really funny or quite different about psychiatry and mental health care as compared to most other disciplines in medicine. That is, normally people go to a doctor if they feel sick. But historically, people go to a psychiatrist because other people think they are sick. The whole idea of going to a psychiatrist or mental health professional yourself is quite novel and started in the Western world in the 1930s or in private practice of Sigmund Freud for the worried well. So most mental health care in mental hospitals was involuntary. Insane asylums or mental hospitals were there for people who disturbed the social order. To get in, required a process of certification. That is a legal process. Insanity is a legal term in which someone is presented to a judge, and a physician and some lay people give a testimony saying, we think this person is insane and ought to be admitted to a mental hospital. So the social role of psychiatry for the longest time has been maintain social order and putting away troublemakers. And we can see all in the history of psychiatry that there has been a to and fro between mad and bad. In the Western world in the 60s, lots of people who had committed crimes were still sent to mental hospitals because it was believed that they were a criminal because of insanity. And these days we do the opposite. There are no more mental hospitals in the Western world. So many people with mental illness end up in prison, even though these are not very good places for the treatment of mental illness at all. So this two-edged thing is still there if we talk about mental illness. For example, in Indonesia, we have the big problem of pasung. Why are people placed in pasung? To protect others around them from threats, either of violence or chasing animals or putting buildings to fire. So it's the family protecting themselves from legal liability. So in this context, if we talk about access to mental health care as a human right, this is quite a modern perspective that is quite at odds with what the role was of mental health care and psychiatry historically. It still has some part of that function, and we should keep that in mind very much. For example, there are some Indonesian psychiatrists who talk about homosexuality as being a mental illness. Well, it's not. But there are some value systems that see it that way. It's not a science, it's some religious perspectives. And it is very important not to mix those up. Healthcare in the Dutch East Indies before 1900 was there for the colonial army, colonial officials, and Europeans who lived there. Before 1900, the colonial state did not feel any responsibility for the health of Indonesians. And the idea was, well, they have their dukun, their own shamans or healthcare providers, we should just not interfere. That is really a self-serving thought that just didn't want to bother about this. The colonial state had to take care of prisoners, forced laborers, and anyone who they had a responsibility. Also, the colonial state felt responsible for the health of Indonesians if they could infect Europeans. So the smallpox inoculation campaign, of course, had this goal to prevent that. And epidemics like the plague, pest, was also very important. And the care of prostitutes because, well, that could infect Europeans. So the first modern mental hospital in the Dutch East Indies opened in 1881 in Bogor, Buitenzorg. It is still there. Today it's Matsuki Madi. Many of the same buildings are still there. And it was the very first form of modern healthcare available to Indonesia. Now, of course, missionary activity, so private initiative, had provided healthcare for Indonesians, some from plantations, some from mission, from the churches. But the state providing modern healthcare, mental health care, was the very first step. It still required that legal aspect of certification. And because mental illness was still very much caught up in all these legal provisions, the mentally ill were still very much kind of like prisoners, and therefore the colonial state felt responsibility. How did people get into that mental hospital? Often if they'd run amok and be violent in public, but most people ended up there because they were found in a state deserted by their family and they could not take care of themselves. And most often the family had deserted them because they were at their wits' end. They didn't know what to do anymore. Most of the mental hospital was kind of peaceful. This modern care followed the introduction of moral treatment in the Western world. Philippe Pinel in Paris and Samuel Tuke in the United Kingdom. The whole idea was Before, mental hospitals were awful places. Inmates were chained up quite regularly and treated quite brutally. And these people thought, look, you need to approach them with kindness and respect. The insane are not monsters. They're not like animals. They're like confused children. So they need some fatherly discipline and gentle care. These innovations worked in the beginning. If you had very enthusiastic staff, small institutions, it worked really well. And here we can see an image of Philippe Pinel freeing the insane in Paris from their chains. And you can see that the insane in this image are not scary at all. They seem to be frightened. And of course, they had good reason. These ideas were picked up by a Dutch psychiatrist, Schröder van der Kolk, and he started a renewal and a modernization of psychiatry in the Netherlands. Then he sent two doctors, one who worked in a mental hospital in the Netherlands and one who had worked in a mental hospital in the Dutch East Indies, to make a survey. How many people with mental illness are there on the island of Java? How many hospital beds are needed for their care? But also they went on some traveling, they surveyed mental hospitals in tropical nations. And in Europe, mental hospitals were often two big wings close together. The tropical model was pavilions spread out. So they made that enumeration, and this led eventually, it took more than 20 years, to that hospital in Bogor. And here you can see the central building. Every Sunday there was gamelan playing. They were set up as agricultural colonies. The idea was put people to work. Work gives meaning to life. It also helps make running the mental hospital so much more cheaply. There were no fences and there was no restraint. So this is the map. Right now, of course, Mazuki Mari is right in Bogor, but at the time it was outside. There were lots of farming areas around where people worked like this, and workshops. And of course, women patients, they worked in the kitchen, in the laundry, and all that. So they were kept busy. The idea is also rehabilitation. Teach people a skill. If they are discharged, they are able to make their own living. The Lawang Mental Hospital opened in 1904, and it's still there. And in Magelang in 1924, and that also is the same very building, still stands there. And in Sabang, Pulau, that building is no longer there. During the Japanese occupation, it was used for military purposes and then disappeared. The colonial vision for mental hospital care was to have these 4 big mental hospitals and 12 clinics in urban areas for acute care. And ideally, in those clinics, you stay maximum 3 months. If you're still ill, then you're transferred to a mental hospital. There were never enough places. This is true worldwide. Never enough beds. The mental hospitals focused on work and rehabilitation and recovery. There were beautiful buildings in rural areas. At this time, there were no medications for mental illness at all. So that was not part of it. The problems, like mental hospital care everywhere, overcrowding, reductions in funding, people with severe forms of mental illness, like dementia, for example, were admitted, they simply would not leave. They would only die there. And a loss of vision, what mental hospitals were for. In the 1930s, it was the best mental hospital system in Asia, the highest number of beds per capita. It's quite interesting that the Dutch focused their care on mental hospital care. After the Indonesian Revolution, things became quite dire, also because of the economic problems of independent Indonesia. In 1963, there were 32 psychiatrists. There was no money to buy electroshock machines, so often it was given straight out of the electrical socket. There were, of course, in the 50s, chlorpromazine or thorazine was available, but it was very expensive and it was only if patients or their families could afford it. Still, in Bogor, there were no locked wards, patients were free to go, they still worked outside in occupational therapy. Then Robert Rubin, a student of a psychiatrist Nathan Klein, who had visited Indonesia, comes with 2 big suitcases full of thorazine and an electroshock machine. And this is introduced in Jakarta. Here you see some images he took of Suharto Herjam mental hospital, the city hospital. It is very different from what they know it today. Patients at work cleaning the tiles. It still looks kind of idyllic. And here we see the doctors who work there. And here right in the background, Kusumanto, the godfather of psychiatry in Indonesia. This is the Department of Psychiatry at the University of Indonesia. Here, this is Kusumanto again, and several of the first generation psychiatrists, many of them Chinese Indonesians, because they simply could not get access to rotations in surgery. Kusumanto, a very powerful person, was the chair of psychiatry at the University of Indonesia, the director of the Directorate of Mental Health in the Ministry of Health, has been called the godfather of Indonesian psychiatry. He trained a new generation of psychiatrists, sent them abroad for further training, and this was the first generation to bring modern psychiatry to Indonesia. His vision was, and I was fortunate enough to be able to interview him in 2006 at his private mental hospital, Dharma Wangsa. His vision was one mental hospital in every province. From mental hospitals, we do public health education, educating general practitioners, and do consultations in hospitals. But also we focus on rehabilitation and outpatient clinics. At this time, Indonesia had a central role in ASEAN and in ASEAN psychiatry. So still, it was leading in Asia. Kusumanto focused on mental hospitals because he told me, once you build a mental hospital, nobody can take it away. So this gave security to the discipline. He hoped that outpatient psychiatry would develop out of those mental hospitals, but it did not always happen. So mental health care best practice, according to Kusumanto, was to provide mental health care in a variety of settings and to provide mental health care in primary care. This is now a demand of BPJS. And it's more an ideal than of a practice. There's currently lots of thinking about how this could be done. And further changes that there's lots of work around in Indonesia right now. Focus on what the patient needs are rather than the diagnosis. It's very important to move beyond that medical model that says we diagnose this and this specific disorder, we give this kind of medication. There is a lot more needed to help individuals with mental illness to function well in society and to lead a productive and meaningful life. For example, to focus on abilities, potential, rather than disability or malfunction, a focus on rehabilitation. Fortunately, over the past 10 years, many patient groups, KPSI, Bipolar Care Indonesia, Into the Light Indonesia, and many others, and we'll hear from Jenny very soon, have become part of all this. And this is very important because Indonesia only has 1,000 psychiatrists for 270 million people. The number of community mental health nurses, I think about 3,000. Clinical psychologists, about 600. It's not an awful lot. If Indonesia had the same number of psychiatrists per capita as Australia, there would be 75,000 psychiatrists. So with such a small number of mental health professionals, the involvement of everybody, specifically the patient groups, is absolutely essential. And they do work very closely with the professionals. I've moved from the vision of Kusumanto, which still focuses very much on mental hospitals, to the vision of Dr. Pandu Setiawan, who unfortunately is no longer with us. He very much was into psychosocial rehabilitation, community-based mental health services, and strongly supported the patient movements. And I think he gave a lead of where mental health care should go in Indonesia. Now, I have, with lots of people, put these two books together. Jiwa Sehat Negara Kuat, which is a variation on what Sukarno used to say about a healthy nation and a strong country, with more than 50 Indonesian contributions about the future of mental health care in Indonesia. It should be provided through the Puskesmas, should be provided in the community. Of course, mental hospitals should stay there as a backup, but it should be integrated, working together with schools, with the consumer groups, etc. So these are lines for the future in a country with a very small number of mental health professionals, but still where a lot could be done by training teachers, physicians, and many others. And yeah, thank you very much. I'm happy to take questions.
All right. Okay. Thank you so much, Pak Hans. Thank you so much. I think for some people, probably what Pak Hans just shared with us are those stories is quite depressing. Sangat menyedihkan ya, perjalanan tentang bagaimana negara pada saat masa kolonial, pemerintah kolonial memperlakukan orang dengan mental health. Banyak sekali pertanyaan yang sudah ada di kolom chat, tetapi I hope Pak Hans you can stay with us and then we will discuss those questions during the Q&A.
Okay.
Okay, so continuing to the discussion about Indonesia, kita akan mengundang Ibu Yeni Rosa Damayanti yang sudah ada di sini bersama kita. Ibu Yeni, selamat pagi. Terima kasih sudah meluangkan waktu untuk bersama kita pagi ini ya Bu Yeni. Bu Yeni, apakah ya? Terima kasih Bu Yeni. Ya, terima kasih banyak ya sudah bisa bergabung. Bu Yeni, ini adalah hari keempat dari pelaksanaan sejumlah rangkaian webinar yang dilakukan antara Universitas Latrobe dengan Universitas Aisyiyah di Jogja dalam rangka mempromosikan dan meningkatkan awareness tentang layanan kesehatan kepada penyandang disabilitas. Hari ini kita khusus membahas tentang apa yang terjadi di Australia dan di Indonesia. Dan mudah-mudahan Mbak Yeni bisa share dengan kami semua di sini selama 20 menit mengenai pengalaman dan juga apa tentang kebijakan pemerintah Indonesia terkait dengan mental health. Terima kasih Mbak Yeni, 20 menit dari sekarang.
Baik, sebentar ini ada kesulitan teknis, saya ingin memperbesar layar saya dulu. Saya izin share screen ya.
Silakan Mbak Yeni.
Ya. Apakah bisa terlihat layar saya?
Bisa banget, bisa. Sudah baik. Bagus Mbak Yeni ya.
Baik. Ya, pertama-tama saya akan mengambil sudut pandang penyandang disabilitas psikososial ya, bukan dari sudut pandang orang dengan gangguan jiwa. Ini sedikit ada perbedaan cara pandang dari sudut disabilitas psikososial atau disabilitas mental dengan cara pandang dari sudut orang dengan gangguan jiwa. Kalau dari cara pandang penyandang disabilitas psikososial atau penyandang disabilitas mental, disabilitas psikososial ini adalah pengalaman yang mana orang-orang dengan gangguan jiwa alami sehari-hari pada saat berinteraksi dengan lingkungannya yang tidak kondusif. Sehingga tidak hanya masalah kesehatan jiwanya saja yang yang menjadi tantangan, tapi tantangan terbesar itu ada pada lingkungannya. Nah, inilah yang menjadi perbedaan yang besar ya antara orang dengan gangguan jiwa dengan penyandang disabilitas. Bukan orangnya sama, tapi maksudnya cara pandangnya berbeda apabila seseorang diposisikan sebagai orang dengan gangguan jiwa dengan apabila dia berposisi sebagai a person with psychosocial disabilities. So that totally different from it's not different, different perspective from if you see them as person with mental illness, you know, person with psychosocial disability, person with mental illness, totally different perspective. Saya nggak ngomong, saya bahasa Indonesia atau bahasa Inggris ya, Ibu?
Eh, yang nyaman saja Mbak Yeni.
Dua-duanya nyaman. Prefernya apa?
Kita lebih banyak teman-teman dari Indonesia, jadi mungkin bahasa Indonesia ya Mbak ya.
Baik, baik, oke. Ya, ya. Jadi apa namanya? Ya, seperti saya sebutkan tadi, saya ambil perspektif dari perspektif from person with psychosocial disabilities. Nah, kalau dari segi kesehatan jiwa, orang-orang mana saja yang masuk dalam kategori person with psychosocial disabilities itu ya semuanya yang mengalami semua orang-orang yang mengalami masalah kesehatan jiwa, yang mengalami hambatan pada saat berinteraksi dengan lingkungan. Kesehatan jiwanya bisa skizofrenia, bipolar, depresi, ansietas, personality disorder, ada macam-macam. Berikut, jumlahnya banyak ya. Kalau di ini WHO memperkirakan 1 dari 4 juta orang di dunia mengalami berbagai masalah kesehatan jiwa. Tentu tidak semuanya masuk dalam kategori person with psychosocial disabilities. Karena person with psychosocial disabilities atau orang dengan disabilitas mental itu tentunya gangguannya harus berlangsung cukup lama dan mengganggu aktivitas hidup sehari-hari. Ada banyak stigma ya terhadap orang-orang dengan disabilitas psikososial di Indonesia, dan ini juga berpengaruh terhadap pelayanan kesehatan yang mereka terima. Seringkali mereka dianggap berbahaya, pelaku kekerasan, padahal mereka seringkali menjadi korban kekerasan verbal, fisik, emosional, seksual. Ini jauh lebih sering orang dengan disabilitas mental prevalensinya dibandingkan dengan orang dengan non-disabilitas mental yang mengalami kekerasan, termasuk kekerasan seksual. Itu angkanya jauh lebih tinggi daripada orang non-disabilitas. Kemudian mereka dianggap bodoh, tidak mampu berpikir, tidak mampu bekerja. Ini dengan dukungan yang baik serta beberapa penyesuaian, mereka bisa bersekolah, bekerja, dan berprestasi. Nah, sebelum saya masuk ke sini, mungkin saya memposisikan diri saya dulu ya kepada teman-teman yang belum kenal. Nama saya Yeni Rosa Damayanti, saya dari Perhimpunan Jiwa Sehat. Perhimpunan Jiwa Sehat ini adalah organisasi penyandang disabilitas yang berfokus pada advokasi hak-hak penyandang disabilitas mental. Gitu. Saya sendiri adalah seseorang dengan disabilitas mental dan adalah ketua dari Perhimpunan Jiwa Sehat. Nah, itu posisi saya pada saat ini. Lanjut ke sini, stigmanya juga mereka tidak punya harapan dan tidak punya masa depan. Padahal dengan dukungan yang baik, baik dukungan keluarga, dukungan sosial, dukungan medis, mereka hidup bisa seperti biasa, seperti orang-orang lainnya. Ini semuanya berdasarkan obrolan keseharian saya bergaul dengan anggota PJS yang semuanya adalah orang dengan disabilitas mental ya. Jadi berbeda dengan orang-orang di setting kesehatan. Orang-orang di setting kesehatan itu biasanya berhubungan dengan penyandang disabilitas mental itu pada saat kondisinya sedang akut, pada saat dia sedang ngamuk atau pada saat dia sedang berobat. Saya berinteraksi dengan penyandang disabilitas mental dalam kondisi keseharian mereka, dan saya melihat bahwa jauh lebih banyak kondisi mereka sedang tidak akut daripada sedang tidak akut, dan ini sangat mempengaruhi bagaimana cara pandang kita terhadap mereka. Walau dengan dukungan yang tepat, penyandang disabilitas psikososial apapun diagnosanya bisa hidup seperti biasa dan berpartisipasi di masyarakat. Nah, ini contoh ya, ini kawan saya yang sebelah kiri ini Mas Edi, dia pegawai Pemda DKI. Yang sebelah kanan ini pemuda tanpa nama. Kalau kita lihat nih Mas Edi ini saya ambil dari Instagramnya dia. Dia pegawai Pemda DKI, steering komite DKI Muda, dia adalah ahli information teknologi, penikmat buku, pecandu kopi, schizophrenia survivor, dan BBM Scholarship Awardee. Orang dengan sama-sama schizophrenia, karena dia tidak mendapatkan dukungan seperti Mas Edi dapatkan, dia berakhir terpasung di sebuah panti di Jawa Tengah. Jadi kita bisa lihat bahwa diagnosa itu nggak ada apa-apanya. Diagnosa itu is nothing gitu ya, artinya dia not define people gitu. dia nggak menentukan orang itu menjadi seperti apa, karena dua orang dengan skizofrenia bisa sangat berbeda tergantung pada dukungan yang dialaminya. Sehingga apabila yang masih punya stigma terhadap gangguan jiwa seperti skizofrenia, bipolar, itu ya stigma itu harus perlahan-lahan kita ubah. Kalau bisa cepat lebih bagus. Oke, nah satu lagi yang penting ya, memang salah satu kebutuhan dari orang dengan disabilitas mental adalah kebutuhan obat-obatan, namun tidak semua ya, karena kebutuhan kita banyak, kita tidak hanya perlu dokter dan obat, tapi kita juga perlu kehidupan lain sama seperti orang-orang lainnya. Kita perlu pendidikan, kita perlu pekerjaan, kita perlu berkeluarga, kita perlu perumahan tempat tinggal, kita perlu sumber income, kita perlu social protection, kita perlu hak untuk beragama, perlindungan hukum dan lain sebagainya. Jadi kebutuhan atas layanan kesehatan adalah satu dari sekian banyak kebutuhan yang kita butuhkan. Ini saya tegaskan karena kalau di Indonesia segala program mengenai disabilitas mental atau orang dengan disabilitas mental itu kebanyakan hanya terfokus pada pemberian obat-obatan dan layanan kesehatan tanpa memperdulikan kebutuhan-kebutuhan lainnya. Tapi tetap layanan kesehatan adalah sebuah salah satu layanan yang penting bagi kita, walaupun bukan satu-satunya. Nah, karena kita di sini berbicara tentang layanan kesehatan, saya akan berbicara mengenai beberapa masalah layanan kesehatan bagi penyandang disabilitas mental di Indonesia. Nah, salah satu masalah terbesar di Indonesia terhadap penyandang disabilitas mental adalah di Indonesia itu tidak ada kebijakan yang mengenai prior and informed consent terhadap yang harus diberikan kepada yang harus bisa dinikmati oleh pasien ya. Nah, di sini perbedaan antara orang dengan orang dengan disabilitas mental ini salah satu diskriminasi yang dialami oleh orang dengan gangguan jiwa di Indonesia, di mana orang non gangguan jiwa itu apabila mendapatkan treatment apapun juga, termasuk medical treatment, itu mereka akan dimintai persetujuan perawatan, persetujuan pengobatan, ada tanda tangan, misalnya mau dibawa masuk ke rumah sakit. Namun bagi penyandang disabilitas mental di Indonesia itu tidak ada keharusan untuk mendapatkan persetujuan dari yang bersangkutan. Nah, ini masalah terbesar ya, karena jelas-jelas diskriminatif, karena harusnya setiap pasien memiliki hak untuk memberikan persetujuan yang jelas tentang treatment yang akan mereka hadapi, yang akan mereka dapatkan. Dan ini tidak dilakukan di Indonesia. Nah, ini ada kaitannya dengan diskriminasi, beranggapan bahwa mereka bodoh, nggak ngerti apa-apa, bukan manusia, tidak punya hak, tidak bisa memberikan persetujuan. Yang manifestasinya adalah tidak adanya hak atas prior and informed consent dalam pemberian pengobatan. Nah, lalu juga ada beberapa itu masalah informed consent, lalu mengenai masalah institutionalization ya. Institutionalization itu adalah sistem di mana penyandang disabilitas mental alih-alih dirawat di tengah keluarga, di tengah masyarakat, dimasukkan ke rumah sakit jiwa atau ke panti-panti sosial dalam jangka waktu yang lama. Nah, rumah sakit jiwa di Indonesia itu kan masih seperti penjara ya, kalau kita lihat di Bogor, di Malang, segala macam itu bangunan-bangunan tua yang jendelanya juga masih berjeruji, masih betul-betul menyerupai penjara. Kemudian masih ada ruang isolasi di rumah sakit, bahkan rumah sakit yang seperti di Jakarta ya, Duren Sawit itu, rumah sakit Duren Sawit yang modern ya, buatan baru gitu, itu masih ada ruang isolasi di mana orang dengan disabilitas mental itu bisa dikurung di sana sampai jangka waktunya lama, pernah ada sampai 2 minggu gitu. Ya, saya pernah waktu itu ya beberapa kali teman saya dimasukkan ke ruang isolasi dan terus terang saja itu adalah tindakan yang sangat tidak manusiawi, dan orang yang tidak apa-apa pun masuk ke ruang isolasi bisa menjadi apa-apa begitu. Tidak ada aturan berapa lama tinggal di rumah sakit jiwa dan panti-panti sosial. Ini bisa seumur hidup, karena selama bisa bayar itu terutama di rumah sakit swasta ya, itu ya tetap bisa tinggal di sana gitu. Kayak seperti di Dharma Wangsa itu ada pasien-pasien yang tinggal di sana lama sekali, sepanjang orang tuanya bisa membayar, dia bisa tetap dikurung di sana. Nah, artinya bahwa beberapa rumah sakit jiwa dan panti-panti sosial, ini terutama yang bayar sendiri ya, yang bukan bayar BPJS, ini bisa berfungsi sebagai tempat pengurungan atau pembuangan bagi orang-orang dengan disabilitas mental, dan ini kalau dari sudut pandang HAM kita sebut sebagai deprivation of liberty. Nah ini ya, beberapa rumah sakit jiwa dan hampir semua panti di Indonesia itu menjadi tempat pengurungan bagi penyandang disabilitas mental yang dibuang oleh keluarganya. Berikutnya ya masuk ke layanan kesehatan yang lain ya. Ini langsung kita masuk ke layanan berikutnya. Di Indonesia layanan kesehatan kita tergantung pada BPJS. Alhamdulillah kita punya BPJS. Ada beberapa kritik terhadap layanan BPJS, misalnya bagi penyandang disabilitas mental untuk antri dalam jangka waktu lama dari pagi sampai sore untuk mendapatkan kesempatan bertemu konsul gitu ya dengan dokter atau psikiater, ini sangat menyiksa. Dan di Indonesia belum ada priority line atau antrian prioritas buat person with disabilities, untuk penyandang disabilitas. Jadi ini salah satu masalah yang besar bagi teman-teman yang harus antri dari pagi sampai sore untuk mendapatkan pelayanan. Lalu treatment yang di cover oleh BPJS itu terbatas ya. Biasanya hanya treatment medis, sementara banyak layanan-layanan yang kita anggap baik itu tidak di-cover oleh BPJS. Nah, juga karena BPJS ini kita hanya bisa ketemu dengan psikiater itu sebulan sekali, apabila obat itu tidak cocok, maka kita harus menunggu sampai waktu konsul berikutnya. Berikutnya, nah ini masalah sikap pemberi layanan kesehatan. Dokter di Indonesia itu jarang memberikan informasi yang jelas dan lengkap tentang diagnosa kepada pasien. Saya tanya kepada teman-teman, dokternya kasih tahu nggak diagnosanya apa? Kebanyakan bilang tidak. Lalu saya bilang, tanyakan diagnosanya apa gitu. Karena kalau kita tidak diberitahu diagnosanya, kita nggak bisa belajar tentang apa yang kita alami, kita tidak bisa mendapatkan informasi tentang apa yang kita alami, dan itu membuat kita tidak bisa edukasi diri ya tentang apa yang kita alami. Sudah tidak diberikan informasi tentang diagnosa, kita juga nggak pernah diberikan informasi yang jelas dan lengkap tentang obat-obat yang diberikan kepada kita. Kita ini obatnya apa, tujuan obat ini apa, efek sampingnya apa, itu nggak dikasih tahu. Gitu. Jadi akhirnya kita nggak mengerti apa-apa gitu tentang obat itu apa, tujuannya apa, efek sampingnya apa, sehingga pada saat kita mengalami efek samping, kita tidak mengetahui bahwa sebentar, handphone saya nyala, saya mati dulu ya. Sehingga kita tidak bisa mengetahui kenapa saya merasa seperti ini efek sampingnya apa, dan kita juga tidak diberikan kesempatan misalnya untuk mendiskusikan apakah ada alternatif terhadap obat apabila obat itu tidak cocok untuk kita. Nah, berikutnya pemberi layanan kesehatan rata-rata masih stigmatif ya terhadap penyandang disabilitas mental, dan tidak memperlakukan penyandang disabilitas mental itu sebagai rekan manusia yang setara. Ini sering sekali ditemui dan keluhan dari teman-teman PJS. Kondisi kesehatan, nah ini penting. Kondisi kesehatan PDM di luar gangguan jiwanya itu cenderung diacuhkan. Jadi banyak beberapa orang teman PJS itu mati muda, umur di bawah 55 gitu ya. Karena ini punya keluhan-keluhan fisik yang lain yang itu tidak dianggap sebagai serius karena semua keluhannya itu dianggap sebagai salah satu gejala gangguan jiwanya. Nah, ini seringkali dilakukan. Kemudian masalah satu lagi adalah psikiater menjadi gatekeeper ya. Apa yang disebut dengan gatekeeper? Gatekeeper itu adalah psikiater di Indonesia masih menentukan mengenai bagaimana penyandang disabilitas mental itu menjalani hidupnya gitu. Dalam arti kata, apakah dia boleh bekerja atau tidak boleh bekerja, apakah dia boleh memilih atau tidak boleh memilih, apakah dia boleh jadi calon anggota, memilih dalam pemilu maksud saya. Apakah dia boleh ini atau tidak boleh itu, psikiater itu yang menentukan. Contoh yang paling jelas adalah surat keterangan sehat rohani apabila kita ingin bekerja. Nah, kalau kita bekerja, buat apa sih surat keterangan sehat rohani? Memang kalau kita punya gangguan jiwa kita nggak boleh bekerja. Gitu. Nah, surat keterangan sehat rohani yang digawangi ya sebagai gatekeeper adalah psikiater. Ini adalah salah satu bentuk diskriminasi terbesar terhadap penyandang disabilitas mental. Kenapa kita harus diperiksa kesehatan rohani kita? Dan apabila kita ternyata memiliki gangguan jiwa, kita tidak boleh bekerja. Nah, ini sebuah tindakan yang sangat diskriminatif. Berikutnya, masalah ketersediaan obat. Nah, obat-obatan itu di Indonesia tidak tersedia secara merata ya. Karena kan obat-obatan kita tergantung dari, kalau yang BPJS ya, kecuali yang bayar sendiri, itu tergantung dari formularium nasional. Nah, gangguan kejiwaan ini kan penyakit kronis ya. Jadi obat-obatan yang kita butuhkan itu bukan cuma sekali, tapi kita membutuhkan dalam jangka waktu yang lama, bahkan bisa seumur hidup. Nah, sementara obat-obatan yang tersedia di layanan di fasilitas kesehatan itu tergantung pada formularium nasional. Sementara formularium nasional ketersediaan obatnya itu di fasilitas kesehatan itu berjenjang. Kalau di tingkat puskesmas obat-obatannya itu sangat terbatas sekali. Rata-rata obat generasi lama. Nah ini obat-obatan jiwa itu kan dibagi dua ya, obat generasi lama dan obat generasi baru. Kalau obat generasi lama itu yang efek samping biasa disebut dengan tipikal antipsikotik misalnya, itu adalah obat-obatan yang zaman dulu ya, terbitan tahun 1950-an itu, yang efek sampingnya beratnya luar biasa, dan obat generasi baru yang dampaknya atau efek sampingnya jauh lebih ringan. Nah di Indonesia yang tersedia di puskesmas itu rata-rata obat-obatan generasi lama tuh seperti haloperidol, yang efek sampingnya itu sangat-sangat berat, banyak yang memilih lebih baik berhalusinasi daripada minum haloperidol misalnya.
Mbak Yeni, sorry ya Mbak, 1 menit lagi ya Mbak.
Baik. Saya akan ya itu akibatnya terhadap penyandang disabilitas psikososial. Obat-obatan yang tersedia di tingkat puskesmas itu sangat terbatas. Dibandingkan obat-obatan yang tersedia di rumah sakit tingkat daerah, tingkat provinsi, apalagi tingkat di pusat ya. Ini dampak dari beberapa obat-obat psikiatrik generasi lama. Kemudian obat-obat psikiatri baru sudah ada, namun jarang sekali dibikin versi generiknya oleh pemerintah, dan sehingga obat-obat psikiatri baru ini harganya sangat mahal, sehingga pemerintah tidak menyediakannya secara merata di seluruh Indonesia. Tenaga kesehatan ya, nah ini psikolog jumlahnya sangat terbatas di Indonesia yang tersedia di puskesmas. Padahal kita sangat membutuhkan psikolog, tapi psikolog nyaris tidak ada, tidak ada ya di puskesmas. Kemudian ya kita track in medical model of disabilities. Yang terakhir adalah masalah panti-panti sosial. Selain dimasukkan ke rumah sakit jiwa, banyak penyandang disabilitas mental di Indonesia yang dimasukkan di panti-panti sosial. Ini satu pembicaraan yang tersendiri, butuh satu webinar sendiri ini membicarakan situasi di panti-panti sosial di Indonesia. Yang terperangkap di panti-panti sosial di Indonesia ini jumlahnya puluhan ribu orang, dan kondisinya seperti ini. Seperti saya katakan tadi, ini membutuhkan webinar sendiri untuk dibicarakan. Oke, ini ada beberapa rekomendasi. Memperlakukan pasien disabilitas mental dengan baik, bermartabat, memberikan informasi yang jelas kepada mereka, berkomunikasi secara setara, sedapat mungkin mengupayakan obat-obat generasi baru, selalu mendengarkan keluh kesah pasien tentang efek samping obat, menyesuaikan jenis dan dosis obat dengan berdiskusi dengan pasien, Setiap treatment wajib dilakukan dengan prior and informed consent. Lalu di tingkat kebijakan kesehatan memastikan kebijakan prior and informed consent diterapkan di seluruh Indonesia, menyediakan obat-obatan yang bermutu di tingkat dasar, maksudnya puskesmas, menyediakan pilihan treatment baik medis maupun non medis, melarang pengurungan penyandang disabilitas mental di rumah sakit jiwa dan panti-panti untuk jangka waktu yang lama, melakukan pengecekan dan evaluasi rumah sakit jiwa atau bangsal psikiatris secara berkala, melarang kamar isolasi dan perlakuan tidak manusiawi lainnya di rumah sakit jiwa, melatih staf bagaimana memperlakukan penyandang disabilitas mental secara manusiawi, menyediakan jumlah psikiater, psikolog, dan seterusnya secara merata. Oke, terima kasih Mbak.
Terima kasih banyak Mbak Yeni atas paparannya. Banyak sekali yang saya sendiri mencatat ya. Saya yakin teman-teman peserta juga mencatat banyak sekali. Banyak sekali ya Mbak, dari mulai kebijakannya yang masih harus terus didorong untuk dibuat lebih menghormati hak, dan juga banyak lagi tadi apa yang ada di masyarakat juga. Oke, Mbak Yeni, we will have another presenter, Mbak Ibu Dr. Mamnuah dari Universitas Aisyiyah, yang juga menulis disertasi tentang skizofrenia di Indonesia ya Bu Mamnuah. Sama dengan yang lain. Oke, saya ingin juga menyampaikan di awal ini bahwa kita kemungkinan akan mundur 15 menit ya. Jadi instead of kita akan selesai jam 2.15. Saya harap ini bisa diterima gitu ya. I'm really sorry for Pak Hans and also Joe. We might have to push back a little bit, like maybe we try to finish at 2:10. Something like that. Terima kasih. So we will have time to answer some of the questions that raised by the participants. Silakan Bu Mamnuah.
Ya, baik. Terima kasih Bu Dina. Terdengar ya?
Ya, bagus Bu. Ya.
Baik Bapak dan Ibu sekalian, para peserta pelatihan, saya mau nyambung saja dari yang disampaikan para pembicara sebelumnya. Sudah banyak sekali ya yang disampaikan. Mudah-mudahan nanti dari saya yang sedikit ini bisa ikut melengkapi, menambah sedikit wawasan. Kebetulan saya ini dosen di UNISA dan mata kuliah yang saya ajarkan adalah keperawatan jiwa. Jadi saya mulai menekuni di kesehatan mental ini tahun 2006. Dari situ kemudian banyak riset dan pengabdian saya yang memang fokus pada pasien dengan gangguan jiwa. Saya mohon maaf, saya lebih banyak mungkin istilahnya gangguan jiwa ya. Tadi kalau kata Bu Rosa ada perbedaan definisi disabilitas mental dan gangguan jiwa. Bapak dan Ibu sekalian, kalau kita lihat di saat Hari Kesehatan Jiwa Sedunia ya, di sana temanya sebetulnya tentang kesetaraan dalam kesehatan jiwa untuk semua. Dari sini sebetulnya ini sangat pintu masuk ya, bagaimana kesehatan jiwa itu menjadi sama pentingnya dengan kesehatan fisik dan lainnya. Ini kalau dilihat definisi kesehatan jiwa sendiri, kalau di Undang-Undang Kesehatan Jiwa bahwa yang disebut sehat jiwa itu adalah orang yang bisa berkembang secara fisik, mental, spiritual, dan sosial, menyadari kemampuan sendiri, dapat mengatasi tekanan, dapat bekerja secara produktif, dan bisa memberikan kontribusi untuk komunitasnya. Sama yang dari WHO juga bagaimana kita itu merasa sehat dan bahagia, mampu menghadapi tantangan hidup, bisa menerima orang lain, dan punya sikap positif baik terhadap diri sendiri maupun orang lain. Nah kalau kita di Indonesia itu kan ada lagu ya, Indonesia Raya ya, bangunlah jiwanya gitu ya. Kalau kita lihat sebetulnya jiwa ini malah disebut pertama kali begitu. Jadi jiwa dan fisik ini sama pentingnya. Nah ini yang kadang-kadang kita itu lebih fokus ke fisik ya. Jadi ketika kita sakit kepala, maka akan dengan mudah kita akan mencari obat sakit kepala. Tapi ketika kita merasa kok saya sedih terus, ya kok saya pengen nangis, kok saya kayaknya jengkel terus, itu kita tidak menyadari begitu ya, bahwa sebetulnya di situ ada masalah dengan kejiwaan kita. Nah ini harapannya ke depannya bahwa kita akan menyadari dengan permasalahan kesehatan jiwa ya, sehingga bisa diatasi dari awal. Nah, di masyarakat ini juga ada 3 kelompok ini, kelompok yang sehat jiwa, kelompok yang risiko, dan kelompok yang dengan gangguan jiwa maupun yang dengan disabilitas mental tadi. Ini, jadi ada 3 kelompok ya, ada yang memang tadi memenuhi ciri-ciri sehat jiwa, ada yang dengan risiko ya, dengan karakteristik yang dia berisiko saat terjadi ke gangguan jiwa ya, ataupun dia akan tetap di sehat jiwa. Sedangkan yang gangguan jiwa juga, nah ini ada di komunitas kita. Dan Bapak Ibu sekalian, tidak ada siapapun ya, pasien siapapun kita yang bisa atau bisa memilih sakit apa begitu ya. Karena memang penyakit itu juga tidak bisa dipilih, seperti di awal bahwa disabilitas itu juga bukan keinginan siapapun ya, dan siapapun bisa mengalami. Nah ini kalau dilihat piramida pelayanan perawatan kesehatan jiwa di kita ya, itu betul tadi kata Bu Rosa, paling banyak itu sebetulnya di bagian bawah ya, ada di keluarga, ada di komunitas. Jadi teman-teman disabilitas mental, pasien yang gangguan jiwa itu ada paling banyak di paling bawah ini. Yang sebetulnya ini justru kebutuhannya banyak dan biayanya lebih rendah. Ya, karena yang sampai dirawat di rumah sakit jiwa kebutuhannya sedikit dan biayanya lebih tinggi. Jadi kalau kemudian kita mau lebih banyak penanganannya, intervensinya itu berbasis komunitas, itu akan sangat membantu ya semua pasien, dan ini jauh lebih murah. Nah ini kalau kita lihat di hasil Riskesdas, saya kebetulan yang Jogja ya, Jogja ini angka nomor 2 ya, tertinggi untuk gangguan jiwanya. Nah itu paling banyak di Kulon Progo, dan yang pernah dipasung itu paling banyak justru di pedesaan. Ini hasil dari Riskesdas, riset kesehatan dasar. Kemudian angka gangguan mental emosional ini juga Jogja juga masih di atas angka nasional ya, dari angka Indonesia sendiri, dan paling banyak itu di kota Yogyakarta. Nah ini dampak gangguan jiwa, jadi memang akhirnya banyak yang karena banyak pasiennya ini yang malah usia-usia produktif ya. Kemudian juga meningkatkan angka bunuh diri, stigma dan diskriminasi ini menghambat ya pasien untuk mencari bantuan. Jadi akhirnya karena takutnya dengan stigma, takutnya dengan adanya diskriminasi, membuat pasien dan keluarga itu tidak mencari bantuan. Jadi malah tadi seperti kata Bu Rosa dan yang lain ya, malah dicarikannya ke orang pintar ya, atau malah disembunyikan, dipasung di rumah. Nah, seperti itu. Pelanggaran hak asasi manusia ini juga terjadi ya, pemasungan, penelantaran, diskriminasi di bidang kesehatan, pendidikan, pekerjaan, perumahan ini juga ada. Kemudian ini contoh-contohnya ya, tadi dikeluarkan dari sekolah, diberhentikan dari pekerjaan, diceraikan pasangan, ini juga ada ya, banyak kasus-kasus seperti ini, ditelantarkan oleh keluarga yang akhirnya dititip-titipkan di panti, itu sampai lama ya. Malah tadi itu saya juga menemukan ya Bu Rosa ya, bagaimana mereka itu dititipkan, yang penting keluarganya itu membayar, sudah ya, jadi seumur hidup ada di sana. Kemudian dipasung dan dirampas juga harta bendanya. Dan ini juga menjadi beban untuk keluarga maupun caregiver dan pemerintah karena memang butuh biaya perawatan dan lama perawatan yang lebih lama. Nah, sebetulnya kalau di Undang-Undang Keswa sendiri sudah diatur ya tentang kesehatan, layanan kesehatan jiwa ini. Upaya-upayanya berupa promotif, preventif, kuratif, dan rehabilitatif. Pelaksananya bisa dari pemerintah, Pemda, maupun dari masyarakat. Dan di sana dituliskan idealnya itu dilaksanakan secara terintegrasi. Jadi ada integrasi bersifat komprehensif dan berkesinambungan. Dan di situ ada koordinasi. Nah ini, kemudian ini kalau dilihat di undang-undang tersebut, hak-hak ODGJ, ya ada 8 yang tertulis di undang-undang tersebut. Ya, bagaimana harus mendapatkan pelayanan kesehatan yang mudah dijangkau, standar pelayanan tadi ya, termasuk obat-obatan, jangan yang generasi 1 begitu, yang generasi 2 yang sudah lebih baik efek terapinya dan minim efek sampingnya. Kemudian ini juga obat-obat harap disediakan yang bagus. Inform consent sebetulnya diatur ya di sini. Harus ada inform consent juga untuk pasien. Kemudian informasi yang jujur dan lengkap tentang data kesehatan jiwanya, perlindungan dari setiap penelantaran, ya tidak boleh ada kekerasan ya terhadap pasien ini, mendapatkan kebutuhan sosial sesuai dengan tingkat gangguannya, dan mampu mengelola harta benda yang dimiliki. Nah, ini di undang-undang itu juga ada istilah 2 ya, ODGJ dan ODMK. Jadi kalau ODGJ itu orang dengan gangguan jiwa, kalau ODMK itu orang dengan masalah kejiwaan. Nah, ini di undang-undang juga diatur untuk ODMK. Ini yang belum sampai mengalami sampai gangguan jiwa berat ya. Jadi harus mendapatkan informasi yang tepat tentang kesehatan jiwanya ya. Pelayanan juga mudah dijangkau sesuai dengan standar, sama seperti haknya ODGJ juga. Nah, kalau di Undang-Undang yang nomor 8 tahun 2016 di sana khusus hak kesehatan penyandang disabilitas, tadi ini sudah disampaikan banyak oleh pembicara sebelumnya ya, sama Bu Rosa. Ini adalah hak-hak kesehatan yang menjadi haknya penyandang disabilitas. Jadi semua informasi, kemudahan akses, kesamaan kesempatan, akses yang aman, bermutu, terjangkau, kemudian harus ada alat bantu kesehatan yang sesuai dengan kebutuhan pasien, obatnya yang bermutu dan efek sampingnya yang rendah, ya. Termasuk dalam penelitian juga itu harus ada perlindungan. Nah, ini adalah upaya kesehatan jiwa yang bisa dilakukan, bisa berbasis layanan kesehatan, bisa dari puskesmas, klinik, rumah sakit, ya, atau berbasis komunitas. Nah, ini juga nanti masuk ke komunitas. Kemudian bisa juga sebetulnya berbasis institusi pendidikan, ya di institusi bagaimana pencegahan, tadi upaya-upaya preventif, promotif, kuratif, rehabilitatif ini juga dikerjakan. Berbasis pekerjaan, amal-amal usaha ya, tempat-tempat bisnis begitu. Nah, ini bentuk pelayanan yang diberikan, promotif, preventif, kuratif, dan rehabilitatif. Kemudian, nah ini adalah hasil riset saya terkait dengan recovery, bahwa recovery pulih itu juga hak pasien ya, dan ini yang saya temukan ketika saya melakukan, ini bagian dari disertasi saya. Jadi untuk bisa pulih itu ternyata pasien gangguan jiwa itu dipengaruhi oleh yang pertama adalah persepsi. Jadi persepsi stakeholder dalam hal ini pasiennya sendiri, keluarga, nakes, kemudian aparat pemerintah, ya. Itu kalau persepsi mereka itu bagus, ya percaya bahwa pasien gangguan jiwa atau penyandang disabilitas mental ini bisa pulih, maka itu akan meningkatkan motivasi mereka untuk terlibat, ya, terlibat dalam memberikan dukungan, memberikan bantuan, ya, terhadap pasien ini. Nah, ini kalau mereka persepsinya bagus, motivasinya tinggi, lalu tingkat keterlibatan mereka pun akan tinggi. Ketika tingkat keterlibatan mereka tinggi, maka ini akan meningkatkan tanggung jawab. Jadi tadi keluarga, ya, keluarga itu ketika percaya, ya, bahwa dia punya persepsi baik bahwa ini bisa disembuhkan, maka keluarga akan dengan sekuat tenaga mencari pertolongan. Ya, begitupun tenaga kesehatan juga begitu. Dan saya melihat dari wawancara, ya, interview, bahwa tidak semuanya keluarga tenaga kesehatan itu punya persepsi yang positif terhadap recovery pasien ini. Nah, ketika mereka punya persepsi yang negatif, yang tidak yakin gitu bahwa gangguan jiwa itu bisa pulih, maka peran tenaga kesehatan pun akan memberikan layanan sekedarnya. Ya, adanya obat generasi 1, ya sudah, itulah yang diberikan. Ya, tidak kemudian berupaya untuk membantu mengupayakan agar di puskesmas tersebut, ya, disediakan obat generasi kedua, ya, obat-obat yang memang membantu pasien ini. Nah, ini. Jadi dari sini kemudian tingkat tanggung jawab ini juga ada yang memang langsung, ya, untuk para nakes itu memang tanggung jawabnya langsung dengan pasien, tapi untuk aparat pemerintah ini tanggung jawab tidak langsung. Bagaimana kebijakan mereka itu juga akan mempengaruhi ke sini, ya. Ketika mereka punya kebijakan bahwa ini harus tadi, ya, dalam hal penyediaan obat saja. Misalnya ketika aparat pemerintah ini kemudian berusaha paham, yakin gitu, ya, persepsinya tadi positif bahwa pasien disabilitas mental, gangguan jiwa ini bisa pulih. Nah, itu akan memberikan dukungan, ya. Dukungannya akan adekuat, ya, tidak sekedarnya tadi, tidak minimal. Itu. Nah, dari sini kalau dukungan kemudian diberikan adekuat, itu akan mempengaruhi hasil. Nah, hasilnya maka akan percaya bahwa oh ternyata pasien gangguan jiwa itu bisa pulih. Kalau ini kemudian percaya, maka akan meningkatkan lagi keterlibatan si stakeholder tadi, ya. Nah, siklus ini akan terus berputar seperti itu.
Bu Mamnuah, mohon
Ya.
maaf, saya ingatkan 2 menit lagi ya, Bu.
Ya, siap, Bu. Dan ini hambatan yang terjadi adalah dari individunya, pasien sendiri, dari stigma. Ya, stigma ini masih kuat sekali untuk di kita, tadi kata Pak Hans, Mr. Han, ya. Memang awalnya banyaknya itu ke dukun, ya, apalagi zaman dulu belum ada BPJS, ya. Itu banyak pengobatan yang terhenti. Kemudian keterbatasan dukungan, ini yang disampaikan Bu Rosa. Dukungan ini nomor 1, ya. Jadi memang luar biasa. Kemudian pelayanan kesehatan dan juga upaya pencarian pengobatan. Itu ya. Maaf tadi ini slide-nya berhenti sebentar. Tapi ini sudah mau selesai. Saya kurang 1 slide nih. Bentar Bu Dina, 1 lagi. Ya.
1 menit lagi, Bu.
Yeah. Jadi ini programnya yang bisa dikembangkan untuk membantu meningkatkan. Nah, so kita sudah mulai ya pembentukan desa siaga sehat jiwa, posyandu keswa, KS jiwa di sekolah itu juga sudah mulai banyak dikembangkan. Nah ini K3 keswa ini juga bisa dikembangkan ya untuk membantu tadi bagaimana yang sehat jiwa itu tetap sehat jiwa, yang resiko itu jangan sampai gangguan jiwa, kemudian yang gangguan jiwa itu tetap bisa pulih dan produktif. Itu ya saya kira itu, dan ini mari kita sama-sama tolong menolong ya, dalam kebajikan, karena memang kebaikan inilah yang nanti sangat membantu untuk saudara-saudara kita semua. Saya kira itu dari saya, kurang lebihnya mohon maaf. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih. Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak Ibu Mamnuah, tepat waktu ya. Oke, baiklah. I would like now to invite all the 4 speakers, Joe, who are Pak Hans, Ibu Yeni, and also Ibu Mamnuah. I have, as you can, some of you also can see already, a lot of questions, but I try to use them. And then the first question that I would ask for Joe, also Pak Hans, because the question is about the experience in Australia. So the first question is asked by our participant from East Java, who is also a health professional working at the Dinas health clinics in East Java. So the question is, what is the model of services, health services for people with mental health? And if there are any differences in the way the health services are being provided depending on their type of illness, or in the, according to the type of their mental health. Like if it's different from mental disorder, gangguan, what is that? Psychological disorder. Forgive me if I'm using the incorrect translation. And also for people with schizophrenia, and what is the role of social workers in healthcare services in Australia? So hopefully Pak Hans and also Joe, you can provide some insights on this.
So, there were quite a few components to that, Dina. I can't speak to the section about the role of social workers because I'm not a social worker. So even though I work with colleagues who are, but I don't feel I can speak to that part. Just going back to the first part of that question regarding models. Look, I guess I can only really speak to my engagement with the participants in the study, and my understanding, and happy for Hans to correct me, is that there's not a different model necessarily for a person with intellectual disability. I mean, they might engage with a specialist who then refers them into either the hospital setting or the community setting. But to my understanding, there's not a separate health model if you've got an intellectual disability. Your avenue in may differ, but that's sort of for across the board. So there's hands waving, so I'm happy for him to elaborate on that part. I can't, what was the other question there?
Yeah, if there are differences but I guess you've already answered that question. If there are any differences in terms of services for different cohort of people with mental health, yeah.
Look, the workforce that I was speaking to were working in the hospital setting and the community setting. So that was more sort of around acute services and sort of more chronic services and follow-on care. But so that was sort of regardless. There wasn't a specific, I didn't discuss with workforce members about specific mental health conditions. As I was talking about in my presentation, my engagement with the participants, they were caring for people with a whole range of mental health conditions. They were in really generic positions.
Yeah.
So that would be more aligned to specialist services. But yeah, I was covering more generic, sort of broader.
Yeah. So I guess probably one more question for you, Joe. We heard from Ibu Yeni and also Ibu Mamnuah and also Hans' presentations, the kind of care that and also healthcare services that have been provided to people with mental health in Indonesia. And we heard about people being put in at the home. So I probably you can share whether those kind of practice are also exist in Indonesia, in Australia, like do people are being sent to the home or in Indonesia we use the word rehabilitation center.
So there are rehabilitation centres, absolutely. I can't give you rates in terms of people with intellectual disability in those rehabilitation centres, but we also do have housing services for people with disability. But again, I'm only really aware of those that are more general, not necessarily specific to mental health. But again, it's not necessarily specific to the intellectual disability. It's more just for people with mental health conditions that I'm aware of anyway.
Thank you so much, Joe. I think we move on to the next questions. We might ask Hans and also Ibu Yeni and Ibu Mamnuah probably can answer because this is something with Indonesia. Pak Hans and also Ibu Yeni juga bisa menjawab juga pasti ini ya. Pertanyaan tentang how do we build a healthcare system that is both practical and sensitive to local customary standards, including the adat law? Because I think the questions comes from the idea that the pasung or the traditional practices in locking up people with mental health is to some extent believed to be part of the traditional customs. So what do you think about this, and how do government works to sort of like stop and prevent this from happening in terms of implementing policy that Indonesia has ratified, like Mbak Yeni bilang, deprivation of liberty. And so to what extent do you think the government has done this, and to what extent also the community, and we are here as part of the community, must be part of that role in promoting the healthcare for people with mental health. So probably Mbak Yeni and then Pak Hans and then Bu Mamnuah. Yeah.
Oke, baik. Ya, bicara tentang adat. Adat itu tidak selalu baik ya. Yang baik kita pertahankan, yang tidak baik kita ubah. Nah, misalnya sudah banyak adat yang kita tinggalkan. Misalnya perbudakan itu dulu pernah menjadi budaya. Di beberapa daerah di Indonesia juga masih ada. Nah, adat itu sudah kita tinggalkan jauh-jauh. Jadi adat untuk kebiasaan memasung orang dengan gangguan jiwa itu juga salah satu adat yang harus kita tinggalkan jauh-jauh dan kita gantikan dengan yang lebih baik. Itu yang terkait dengan pemasungan sebagai adat ya, itu adat yang harus dihapus. Kemudian mengenai bagaimana untuk mempunyai sebuah sistem yang baik di Indonesia untuk penyandang disabilitas mental, itu yang pertama-tama sistem tersebut harus berdasarkan kepada pemenuhan hak-hak penyandang disabilitas mental itu sendiri. Hak kesehatan itu kait-mengkait dengan hak-hak lainnya, termasuk hak atas recognition before the law ya. Karena kan kalau kita bicara soal informed consent, itu kan basisnya kenapa penyandang disabilitas mental itu tidak diberikan hak informed consent, karena mereka dianggap tidak memiliki posisi sebagai subjek hukum, mereka tidak punya legal capacity gitu. Jadi dia berbasis hak dan tentunya karena berbasis hak, perlakuan terhadap mereka juga harus menghargai hak-hak mereka, termasuk bagaimana memperlakukan mereka ya, hak atas informed consent dan lain sebagainya, dan juga hak ketersediaan obat-obatan yang tidak diskriminatif antara kota dan desa misalnya, karena kalau di puskesmas itu semuanya haloperidol itu yang efek sampingnya setengah mati gitu ya. Padahal harusnya obat-obatan yang tersedia di kota juga harusnya tersedia di desa, karena ini kan kronis ya. Nggak mungkin setiap kali mau berobat itu harus ke kota dulu gitu ya, yang jaraknya bisa nyebrang pulau kalau di beberapa provinsi di Indonesia. Jadi ketersediaan obat secara merata itu salah satu di antaranya. Ketersediaan pengobatan lain yang bukan hanya pengobatan psikofarmaka, seperti misalnya konsultasi psikologis dan lain sebagainya, itu harus disediakan juga dan harus di-cover oleh BPJS. Dan terkait dengan pasung, ada satu kritik besar terhadap pasung, yaitu penyelesaian pasung itu masih terkonsentrasi kepada memberikan obat. Padahal tadi seperti sudah dikatakan oleh Ibu Mamnuah ya, bahwa yang paling penting bagi recovery dari orang dengan gangguan jiwa atau orang dengan disabilitas psikososial itu adalah satu persepsi, baik persepsi dia, persepsi masyarakat, persepsi pemerintah, pemberi layanan kesehatan. Yang kedua adalah support yang diberikan kepada dia. Nah, jadi kalau hanya dilepaskan dari pasungan, kemudian dibawa ke rumah sakit, di rumah sakit dikurung lagi gitu ya, terus udah gitu dibawa ke panti, di panti dikurung lagi bertahun-tahun, itu dari mulut macan ke mulut buaya. Sehingga program Indonesia Bebas Pasung harusnya komprehensif, tidak hanya menangani masalah obat-obatan saja, tapi juga menangani masalah perumahan, mengenai masalah pekerjaan, pendidikan, penghasilan, social protection, penghilangan stigma di masyarakat, dan lain-lainnya. Jadi harus multisektoral. Penanganan pasung di Indonesia yang hanya mengandalkan obat-obatan pastinya gagal, sudah bisa dipastikan. Jadi itu penanganannya harus komprehensif. Obat-obatan itu adalah salah satu di antaranya. Dan segala penanganan itu harus berbasiskan kepada pemenuhan hak-hak penyandang disabilitas mental. Itu dari saya, terima kasih.
Terima kasih, Pak Hans.
Sure. You can hear me all right? Can you hear me all right?
Yeah.
Good, good, good. Okay, so the question, what to do? Now, one thing that I hear too often in Indonesia is, what could the government do? I think the initiative is taken these days by civic groups, consumer groups, volunteer groups, and they're everywhere. And they do remarkable things, and often by working with local puskesmas, initiate new programs. There is a great example in Kebumen. There was an unofficial pantry not for people with schizophrenia, and some volunteers from Yogyakarta have changed it, have built an additional housing facility. The people there now get regular medical care. And this is not because the government organized something, but because these volunteer groups got together. They negotiated with market sellers to get food there. They negotiated with puskesmas so that regular medical care was being provided. These things have to be accomplished on a local level, and they can be accomplished on a local level. Now, governments have issued all kinds of things for the puskesmas, so the minimal service standards, that is standaard, pelayanan, minimal, and they include visiting people with chronic forms of mental illness, schizophrenia at home, and taking care of them. This is all very, very good, and this is all very important, but it's only a start, because most doctors at the puskesmas are extremely busy already. So I think mental health in Indonesia meant all hands on deck. It's the volunteers, it's the teachers, it's anyone, the kader kesehatan in every group. And in that way, I think quite a bit can be accomplished. What we see right now is that if you're middle class, if you're relatively wealthy, you can afford seeing a psychiatrist or psychologist in private practice, but this is only for a very small group. Now, it's great that that is possible. And the question is now, how can this be generalized? How can this be feasible for more people who do not necessarily have the funds. Now, there are things in BPJS that have to be tweaked that way. For example, transport to see a doctor and go back is not covered today. Now, in Eastern Indonesia, that can take quite some time. It can take a day of traveling for the patient. Often you need to take a family member as well. So that means 2 days loss of work, transportation costs, etc. This is, for many families, quite a considerable expense. So with tweaking reimbursements, there's quite a bit that can be done. But I think the most important thing that's happening in Indonesia is the consumer groups or the patient groups, because they can articulate from the perspective of orang dengan gangguan jiwa, this is what we need. This is what is important. And I know that the Ministry of Health has been talking to these groups and there have been lots of meetings and nothing officially has yet happened. I hope it will. Because one thing that happened with the pandemic is that people in Indonesia have become far more aware of anxiety and depression. So the more common mental disorders. There's no national depression strategy. There's nothing around anxiety. Prozac is available through Puskesma, but very few actually stock it. There's a lot that needs to be done there. Nonetheless, we should not forget the people with severe and persistent forms of mental illness, because often tend to be from poor families. They often fall in between the cracks. They don't have their KTP or the personal identity, so they cannot enroll for health insurance. There are all kind of programs underway on the local level to make sure that they get their identity papers and then can enroll in BPJS. So again, these are the things that are going to make a difference in the very near future. Sadly, during the pandemic, the division of mental health or community psychiatry in the Ministry of Health, people thought, well, maybe abandon it. Now, that fortunately didn't happen, but it goes to show that within the Ministry of Health, within all the health districts, mental health is not a top priority. And we hope that with lots of activism, we can change that. Because loss of quality of life, loss of DALIs related to mental illness is quite considerable and justifies quite a bit more attention. Before there will be sufficient mental health personnel, that will be a long time. It takes 10 years to educate a psychiatrist. A mental health nurse takes less time. Nonetheless, to get a sufficient number of mental health professionals will take a considerable time. So therefore, it is important to enroll everybody who is willing, either through the consumer groups, the carer groups, community groups, groups associated with pesantren or churches, any group who is willing to participate.
Great. Thank you so much, Pak Hans. Ibu Mamluah, ada yang mau ditambahkan? Oke. Ibu Mamluah, mau ada yang ditambahkan 1 menit?
Ya, sedikit.
Kalau tidak,
Jadi
kita...
kalau untuk di Indonesia sebetulnya sudah ada juga ya pergub peraturan gubernur tentang pemasungan ini, tapi memang dalam pelaksanaannya masih banyak kendala. Yang paling utama tadi ya, stigma itu memang masih sangat kuat, dan tadi upaya-upaya pemerintah termasuk di BPJS walaupun masih banyak kekurangannya ya di sana sini, tapi ini sudah cukup membantu untuk pasien, karena kalau zaman dulu itu banyak mereka putus obat karena sudah habis-habisan ya, tanah rumah itu udah pekarangan sudah banyak dijual untuk pengobatan. Dan tadi betul kata Pak Han ya, Mr. Han, bahwa memang ini untuk sampai membawa pasien ke pusat layanan kesehatan itu memang transportasi itu belum dijamin. Nah, ini juga masih menjadi kendala untuk keluarga-keluarga yang memang masih terbatas ya. Oke. Itu. Kemudian Sekarang sedang dikembangkan TPKJM ya, mengembangkan tim pengarah kesehatan jiwa masyarakat yang itu anggotanya terdiri dari multi sektor juga di situ, dan ini mudah-mudahan dari situ akan mulai ya pelayanan kesehatan jiwa ini bisa terkoordinasi, komprehensif, dan bisa continuity of care ya, berlanjut. Itu Bu Dina.
Oke, terima kasih Bu Mamnuah. I think that's where we should stop. I know there are still some burning questions from the participants, but I would like to again thanks to our 4 speakers and Andrew previously who has left. So I guess talking and discussing about mental health and the services that have been provided both in Australia and Indonesia cannot be discussed in merely 2 hours. There are so many things that needs attention, and especially from colleagues from Indonesia. I know you have lots of questions. So for Joe and Pak Hans, since the day one we launched this program, they already a lot of questions asked by most of the participants who are nurses, midwives, students of nursing and student of midwifery, about the need for training, the need for more knowledge, the need of how they can understand and interact better with people with disabilities, different types of disabilities. And we try to cover that all within 5 weeks. And so this particular sessions is especially very important because I think the public discussions around mental health and awareness around mental health are still very closely limited, as Mbak Yeni has said, and also Ibu Mamnuah and Pak Hans said. And I guess the key takeaways from this is that both in Australia and Indonesia, healthcare services in urban and also in rural areas could be a problem. And because of the level of services that are provided in the geographical differences can influence the health outcome. And in fact, in Indonesia, in particular, with lots of islands that are remote from urban cities, that means the problems is even bigger. But I think hopefully this webinar and also the other webinars that we are going to have until the end of the month could provide the participants here with more knowledge and the interest in getting more skills and training, and hopefully that can make us part of what Pak Hans said. We can be part of the community that can start talking and then build awareness among our closest community, like to our families and also friends, about mental health and the need for more engagement, and also the need to increase our knowledge about mental health and also other forms of disabilities, so we can be part of the fulfillment of the rights of people with disabilities. Thank you so much. I cannot say how thankful I am, and also the rest of the committee, for Joe, Pak Hans, Ibu Mamnuah, dan Ibu Yeni. Hopefully this can be the beginning of our collaboration. So hopefully in the future we can meet you all in person and we can do similar or even more advanced activities than what we have today. So thank you so much, and I hope you have a great weekend. Thank you.
Thanks, Dina.
Thank you, Joe. Thanks, Pak
Terima
Hans. Thanks,
kasih.
Mbak Yeni. Thank you, Ibu Mamnuah. Thank you, everyone who are attending this webinar. And thank you also Pak Hikmat and also Mbak Yanda dan Mbak Nastiti as the sign language interpreter. Thank you.